of Puduvai
Zoom.
Pedicon for giving me this opportunity.
Medical mission.
Can you hear me, sir? Sir, can you hear me? Sir, can you hear me, sir?
Yes, sir.
Thank you very much. I thank for the kind opportunity by the organizers of Puduvai Pedicon to invite me. I was planning to come there physically, but today morning there was a cardiac catheter emergency that I had to take up into the cath lab urgently, and hence I tender my apologies for not being present physically. In the next few minutes, I will talk about hypertension in children.
Sorry, sir. Can you make yourself visible, sir?
Yes.
I am.
You will have to switch on your video, sir.
Madam, it is switched on. From my end, it's switched on, madam. Are you able to see my slides, madam?
Your
Yes, sir.
slides
Yes,
are
sir.
visible,
Yes, sir.
sir.
Yeah, actually, from my end, I have switched on. But madam, in view of time, let me
You're
go
visible,
ahead with the
sir.
talk. In
Thank you,
case
sir.
if I am not visible, also let the talk go on.
Yes, sir. Yes, sir.
Thank you very much. Very often systemic hypertension is largely asymptomatic, and hence only a very careful examination by the pediatrician is going to help in the diagnosis. But rarely a very severe hypertension can lead to refractory headaches. Sometimes they may present as seizures, almost like a hypertensive encephalopathy, recurrent unexplained seizures. Sometimes they may present with intense vomiting, features of raised intracranial tension. Sometimes there can be severe retrosternal anginal form of chest pain due to myocardial oxygen supply mismatch. It may present with palpitations, or it may present with breathlessness. Blood pressure assessment should be a strong part of pediatric examination. One of the recent common cause of hypertension is primary hypertension, especially in relatively grown-up children who are overweight, who have a strong family history, who are stressed due to either their high expectation for studies, or they are often sedentary and often follow very poor lifestyle habits like, all sorts of junk eating. But secondary hypertension is often far more serious. Whenever it is untreated, it leads to stroke, maybe myocardial infarction, heart failure, and renal failure. To name a patient as hypertension, we need to have a definition. So if you look at the definition, the blood pressure more than 95th centile is called hypertension, and the blood pressure more than 90th centile is called pre-hypertension. So it becomes very vague. So what is a centile? We are aware that the National Heart, Lung and Blood Institute has given a standard nomogram for following what is called as a centile chart. So for example, the picture that I have listed here, it is the blood pressure level for girls by age and height. So the age from 1 to 18 is listed on this first column. And then we have height, different heights. So we will have the 5th centile, 10th centile, 25th, 50th, 75th, 90th, and 95th centile. So this is the centile of the height. So since the blood pressure is highly related to the body surface area, we need to factor in the age, the height as well. So then you look at what is the systolic blood pressure. The blood pressure centile is given as 50th centile, 90th centile, 95th centile, and 99th centile. Let us talk about, you are seeing a child who is 5 years of age, and when you look at her height, she is a little on the taller side. So her height was in the 90th centile, and you drop down on the 5th year, 112 is her 90th centile, and 113 is the 95th centile. Let us assume that this girl's blood pressure is 112. then she will come into 90th centile. That means she's pre-hypertension. If her blood pressure systolic is 113, that means she is more than 95th centile, which will become hypertension. Now we have to further classify as is it milder form or severe form. So this is called a stage 1 hypertension and stage 2 hypertension. If it is stage 1 hypertension, it is between the 95th centile to 99th centile, add plus 5 millimeters of mercury. Up to that is stage 1. That means it is relatively easy to be controlled. Stage 2 means blood pressure more than 99th centile plus 5 millimeters of mercury. So let us assume in the same girl, a 5-year-old girl whose height corresponds to 95th centile. I have my 95th centile of 99th centile of the blood pressure is 120. So if I am recording a blood pressure of 130, that means 120 plus 5, 125. It's even more than that. So that means her blood pressure is stage 2 hypertension. So this is how we need to see. So this is for a girl. So let me show another picture. This is for a boy. I have not contaminated the chart. So the columns are 5th centile, 10th, 25th, 50th, 75th, 90th, and 95th. This is the height, and this is the age. You have to find out what is the blood pressure centile, and then find out whether the patient is stage 1 or stage 2. The methods of observation, still for a traditional person like me, a sphygmomanometry works the best. Some few years before we were using mercury manometers. Now mercury is highly toxic, and hence we all have shifted to aneroid manometers. So whenever you are doing with an aneroid sphygmomanometry, patient has to be calm, no anxiety, sitting quiet for 5 minutes, back is well supported, both feet on the floor, elbow is supported at heart level, either on your lap or on the table, and then you have to put a cuff of appropriate height. The cuff width should cover 70% of the arm length, and the cuff length should cover 80% of the arm circumference. So this is one of the best method of assessing. You yourself have got a full control. The other method is the same thing can be done by oscillometry also. This is Dynamap, an automatic BP apparatus. So this is by the principle of oscillometry, and the same thing can be practiced. Oscillometry can also be practiced by wristbands, which are even more friendly for the patients. Oscillometer can be without long wire circuits, like more and more miniaturized circuits. And this is oscillometry on an ambulatory blood pressure, which means it will record for 24 hours and give you the trend of the blood pressure. If it is a white coat hypertension, only in front of you the child will have hypertension, and at home the child will not have hypertension. So this is recorded by the ambulatory blood pressure monitor. For a good clinician, I would still say sphygmomanometry works better. So use an aneroid manometer, have at least about 4 cuffs, and try to do it yourself in the clinic. The common cardiovascular causes of hypertension will be coarctation of aorta, takayasu aortitis. In young babies, it can be due to neonatal aortic thrombosis or middle aortic syndrome. I'll show a couple of examples. Coarctation of aorta is a relatively common problem. This is an angiogram of the aorta. So this is the arch of the aorta. You can see that after the subclavian artery, there is a tight narrowing of the coarctation at this level. So this is called coarctation of aorta, which is a narrowing after the left subclavian, where the aorta continues as the descending thoracic aorta. So this patient will have a weak femoral artery bounding upper limb. So the blood pressure difference will be there more than 20 millimeters between upper and lower limb. And this is relieved by a stent angioplasty. And following the stent angioplasty, there is equalization of the pressure. What is coarctation of aorta? Coarctation is a common condition of about 5% of all the congenital heart disease. Upper limb will have hypertension, lower limb will have lower pressure. So recording upper and lower limb blood pressure is extremely vital for the diagnosis. In newborn baby, we tend to prefer surgery because the chances of restenosis after a catheter intervention is high. But when it is an infant or a young child, balloon angioplasty is good. And in an older child and adolescent, stenting is good. Sometimes when you do surgery in a newborn baby, there can be post-surgical recoarctation. That means again a narrowing that happens due to scarring of the surgical site. And in these patients, you have to use a ballooning or a stent angioplasty. This is a newborn baby who presented like a cardiogenic shock with ventricle not contracting at all. So the diagnosis was actually dilated cardiomyopathy. The coarctation was missed out initially, and subsequently on a careful suprasternal view from the neck, a tight coarctation was observed. And this coarctation was balloon dilated, and the balloon dilatation results in normalization of the blood flow here. You can appreciate the aorta opens out with a balloon dilatation, and immediately the left ventricular function improves. So sometimes in a newborn baby also, if the baby is very plasty in order to relieve the coarctation. The next condition is Takayasu's aortitis. Takayasu's aortitis is basically a aortitis due to immune pathology. You can appreciate that the whole of the middle thoracic aorta is sclerosed and it is tightly narrowed. And the moment it is diagnosed, it is relieved by a long vessel stent, and the stent completely relieves the obstruction. And you can appreciate here, the entire aortic obstruction is totally relieved in this by this stenting. Whenever it is Takayasu disease, the disease has to be controlled with appropriate doses of steroids in order to ensure that the ESR and C-reactive protein come back to normal. After getting the disease into control, you can start steroid-sparing drugs like methotrexate or mycophenolate mofetil. Appropriate antihypertensives have to be used. We need to exclude tuberculosis by doing Manto and other tests because tuberculosis is a common association. There is another similar condition called middle aortic syndrome, wherein aorta is occluded at varieties of levels. Here you are finding the descending abdominal aorta below the level of diaphragm. You can appreciate the superior mesenteric artery, renal arteries, and the whole of the aorta is tightly narrowed here. So this again results in hypertension. All of them will clinically appear like coarctation, but these are aortic narrowing at different levels. So here again, syndrome. Middle aortic syndrome is an obstruction from left subclavian artery to aortic bifurcation at any level. Some of the common associations are Williams syndrome, multiple neurofibromatosis, which is also called as von Reckling-Hausen's disease. These are causes of aortic narrowing. Rarely you can have newborns presenting with aortic obstruction. This is an abdominal aortic Doppler of an abdominal aorta presenting with a large thrombus. You do a CT scan, you identify the aorta with a large thrombus here, which is not filling the descending femoral arteries. So you can see that the aorta is cut off by the aortic thrombus, and these patients are managed with catheter-based thrombolytic therapy. It's common after neonatal umbilical artery catheterization, sometimes birth asphyxia, sometimes thrombophilic disorders such as factor protein C, protein S deficiencies, or it may be due to sepsis also. The renal reasons, it can be renal parenchymal disease like glomerulonephritis, pyelonephritis, Hinox-Schönlein purpura, hemolytic uremic syndrome, or early presentations of polycystic kidney disease. But renal vascular disease are come into the purview of cardiologists, renal artery stenosis or renal vein thrombosis. An example of a patient who presented with hypertensive encephalopathy and recurrent seizures, you can identify a tight narrowing of the left renal artery, and this renal artery tight narrowing produced severe hypertension, which is relieved by a stent angioplasty of the left renal artery, which results in complete normalization of the perfusion of the left kidney, and this results in normalization of the hypertension. Sometimes we need to understand that renal artery stenosis will be very difficult to clinically examine. In a quiet child, you can appreciate a renal bruit on auscultation, and it may present as a dilated cardiomyopathy due to severe uncontrolled hypertension and often causes hypertensive encephalopathy. This was a patient who presented with hypertensive encephalopathy, bilateral renal artery stenosis, both of which were stented. You can see a right renal artery stent and the left renal artery stent, both were stented, and the patient was saved from developing kidney failure. Other reasons are central nervous system reasons like polyneuritis, Guillain-Barré syndrome, or increased intracranial tension due to tumors. Drugs like chronic steroid use are sympathomimetics. Some of the tumors like Wilms tumor or neuroblastoma. Various forms of autoimmune diseases like systemic lupus, chronic immobilization due to trauma or spine injury, or sometimes malignant hyperthermia. The drug management will vary. If the patient is presenting with acute left ventricular failure or congestive heart failure or in a hypertensive urgency, diuretics are needed like IV Lasix. In coarctation, typically we prefer beta blockers. If the patient is having unilateral renal artery stenosis, we prefer to give angiotensin converting enzyme inhibitors. In grown-up child, we use calcium channel blockers. In younger children, calcium channel blockers is not utilized. In diseases like pheochromocytoma, we give alpha blockers in combination with beta blockers. Whenever they present with severe emergencies, sodium nitroprusside, which is a vasodilator, and if they are continuing to be refractory, oral drugs like clonidine or hydralazine. More important, lifestyle measures are extremely important, and where the pediatrician plays the major role. Teach the child about diet rich in potassium, which means plenty of vegetables and fruits, and trying to cut off all the bakery items and other food items that will contain high amount of salt. Low calorie, high fiber diet. Avoid sedentary state, promote lot of play and activities, active exercises. Try to give a stress-free environment by avoiding the parents to stress the child with higher and higher expectation about their education, and avoid addiction to drugs as well as gadgets. So the take-home messages for pediatrician will be, as a part of routine examination, try to do a 4-limb blood pressure whenever a well child comes to you for a checkup, and here you can use automatic apparatus. But during a clinic visit, at least one comfortable sphygmomanometry you do yourself when the child is comfortable, to get a feel of the blood pressure yourself. Understand that lifestyle measures are extremely important to prevent these children from having worsening of hypertension. Identification of secondary causes is vital. I primarily stressed on cardiovascular and renovascular conditions because these are the conditions where I directly do interventions in the cath lab to get them out of the reasons for hypertension. And most of the cardiovascular and renovascular diseases have got proper interventional solutions that can be offered in the cath lab. I thank you very much for the opportunity given to me. Thanks a lot.
Thank you very much, sir. You explained well about the hypertension in a calm, comfortable manner without any tension. Now the topics are open for discussion. First to the cardiologist, sir, Dr. Sivakumar, sir.
If we do not
Any
have any
questions about
queries from the
question?
floor,
To orthos, sir. Any queries regarding orthos? I have one doubt, sir. You said the importance of treatment of CTEV from day one itself. You insisted well. Then the only one doubt is the osteomyelitis, treatment of osteomyelitis. You said the IV antibody for 6 weeks parenterally. In any point in time, can we switch it to oral, sir? Or full 6 weeks course IV only?
No. 6 weeks is not a parental. As long as the child is in the hospital, you can continue parental antibiotics for a week or 10 days. Then continue antibiotics. You can switch out to oral antibiotic for another 4 weeks, 4 or 5 weeks.
Thank you very much, sir. There is no queries. We can wind up session.
thank you so much, sir. I now request the chairperson, Dr. J. Balasubramaniam, to hand over the memento to the speaker, Dr. Sundarajan.